Hello, my name is Taylor Heap. I'm a fourth-year medical student at the University of Colorado School of Medicine, and I'm excited to share with you all my case study for this VR imaging course. And the case study will be on facial fractures and trauma. We will begin with our patient case. The patient is a 41-year-old male who is previously healthy, who is found down unresponsive with findings concerning for complex facial trauma in the setting of an assault. The patient had no known past medical history, past surgical history, and did not take any medications. And per the patient's family, the patient was reported to be fully independent prior to presentation. The patient presented at an outside hospital, and initial imaging obtained at that outside hospital was consistent with extensive facial fractures, intracranial bleeding, and elevated intracranial pressure. At that point, as the patient was still unresponsive, the patient was intubated and sedated for airway protection and underwent decompressive hemicraniectomy at the outside hospital to manage the elevated intracranial pressure. The patient was then transferred to the neurological ICU for further stabilization, monitoring, and progression of care. Once in the neuro ICU, the patient was afebrile and was hemodynamically stable with a blood pressure of 120/62, a pulse of 79, and intubated with respiration rate of 16 and oxygen saturation of 99%. On examination, the patient was intubated and sedated, found in bed with a cervical collar. The cardiovascular exam was pertinent for regular rate and rhythm without murmurs. Pulmonary exam was pertinent for mechanical breath sounds in all lung fields, and the neurologic exam was pertinent for a reactive right pupil to light, and then the left pupil was unable to be assessed due to the periorbital swelling in the setting of trauma. Additionally, the patient had intact corneal and cough reflexes and was able to localize to pain in the left upper extremity, withdraw to pain in the left lower extremity, and had no motor response in the right upper or right lower extremity. All of those findings consistent with severe neurologic injury. Initial imaging upon arrival in the neuro ICU included extensive CT and CT angiography head and neck imaging, and while there were many findings throughout this patient's course and stay, the findings I wanted to point out today included the following: extensive skull base and maxillofacial fractures, largely summarized as right predominantly Lefort 1, left combination Lefort 1, 2, and 3 fractures, left zygomatic maxillary complex, bilateral nasal orbital ethmoid complex fractures, inner and outer table of the frontal sinuses fractures, left sphenoid body and greater wing extending to the superior orbital fissure without involvement across the optic canal, right sphenoid greater wing without involvement of the optic canal or orbital apex, and finally bilateral orbital blowout fractures. All of that to say, this patient presented with incredibly complex fractures throughout the face and cranium, leading to the patient's very complex and severe presentation. Before we go into the imaging and scans, I did want to touch a little bit first on the normal anatomy of the skull and facial bones, as this patient's fractures are quite extensive, and I want to go over what looks normal first. So bringing this in, here in the posterior aspect, we have the occipital bone. More superior to that, we have the parietal bone. Inferior, the temporal bone, which is connected via the zygomatic arch to the zygomatic bone. And then deep to that, in this angle, you have the sphenoid bone with the greater wings out laterally, so you can see over there. And then on the anterior and superior aspect of the skull, we have the frontal bone, and then the nasal bones as well. And then deep, we have the lacrimal bones and the ethmoid bones as well, where the orbital plate, the middle nasal concha, and the perpendicular plate are all housed. Then we have the maxilla, and within the nasal cavity, if you will, we have the inferior nasal concha as well as the vomer. And finally, we have the mandible right here as well as all of the teeth. Now, moving into some nomenclature and clinical correlates, I wanted to discuss Lefort fractures. So Lefort fractures are a radiographic pattern of fracture of the midface that involve the the pterygoid plates of the sphenoid bone. So right there, if you can kind of see that. There are 3 different classifications, increasing in severity. The first one is Lefort type 1. This involves separation between the hard palate and the dentition from the midface. And as you can see here on the left, it is the least extensive of the 3. Moving along, we have Lefort type 2, which involves the medial midface. It's a little bit more extensive. Finally, Lefort type 3, complete separation of the midfacial skeleton from the cranial vault. And as you can see on the right, it is the most extensive. As you increase from 1 to 2 to 3, you do increase in severity of the fracture, and that also tends to correlate with a more severe or intense mechanism of injury, such as extreme trauma in the setting of assault or a very severe motor vehicle collision. The patient in this case had features of all 3 Lefort fracture classifications. And this little mnemonic at the bottom I thought was just kind of cool. Speak no evil for Lefort 1. See no evil for Lefort 2, and hear no evil for Lefort 3, referring to the degree of extension of each of those fractures. Now, at this point, I'm going to go back to the case progression and the normal anatomy to be able to better visualize the patient's scans right here. And so first, with the 3D rendering, I decreased the amount of external tissue and fat and fascia as well as edema to be able to give a better image of the bones of the skull and the face. So here, just from a 3D perspective, you can already kind of tell that there are quite a few fractures and deformities. So there is a fracture up here at the left frontal aspect, and then you can also see the bilateral orbital blowout fractures. You can see those right there, as well as right there surrounding the orbit bilaterally. The nose and the nasal bones are a little bit harder to see, but there are some more fractures and injuries right there as well. Additionally, there is some injury on the right side, although as denoted in the CT reading, the right side was a little bit less severe in terms of the presentation and the fracture than the left. Moving over to the left side, we see the zygomatic arch fracture leading from the temporal bone and then into the temporal bone right here, leading into the zygomatic arch, and then now into the zygomatic bone, where you have fractures there and there. Additionally, we also have some abnormalities along the superior or the frontal bone as well. And the other obvious finding here that we can see is this patient does not currently have this part of the skull plate. And so, as I mentioned at the beginning of the case, at the outside hospital, the patient underwent a decompressive hemicraniectomy, which means that because of the patient's significant injuries, there was some swelling and bleeding within the brain. Because the skull is a rigid, defined structure, when there is swelling or bleeding in the brain, it only takes a little bit of increased pressure to cause catastrophic effects, including brain stem herniation and herniation of other parts of the brain that can be fatal. And so in this case, the patient had a decompressive hemicraniectomy to allow for some additional swelling while also utilizing medical management to decrease that intracranial pressure. Additionally, you can see these little clips right here, which I believe to be surgical clips as a result of the decompressive hemicraniectomy. And this tubing right here, it is a little unclear what this is. I do believe that this is likely an intracranial pressure monitoring catheter or tube or whatnot to be able to monitor the intracranial pressure during this patient's recovery. And then additionally, the other thing I want to point out is this patient does have an ETT tube or an endotracheal tube through the oropharynx. Here you can see the tube enters the oropharynx and then it goes into the trachea there. And then I also just wanted to give a brief view with the cross section as well, so I can pull that up right here. And so here now we can look at the cross section of the skin as well. While not perfectly coronal, you can see here as we move from anterior and move posteriorly, that there are some fractures here up at the top and some abnormalities here as well. And then we can continue moving on. And then here you can also see the absent skull bone right there on the left compared to the right, as I discussed, due to the decompressive hemicraniectomy. Moving along, for further case presentation, on hospital day 15, the patient underwent surgical placement of both a tracheostomy and a percutaneous endoscopic gastrostomy or pig tube. These items are incredibly common in patients that have prolonged illness, have prolonged ICU stays, or have undergone catastrophic injuries or illnesses that result in them needing prolonged mechanical ventilation support and nutrition support. The tracheostomy provides access for long-term ventilatory support, as I mentioned. While the patient does currently have the oropharyngeal airway, that is not something that the patient can have long-term, and so the tracheostomy allows for long-term ventilatory support. And this is a direct tube from the exterior surface through or just inferior to the cricoid cartilage, and then directly into the trachea, where there's a cuff that then allows the ventilatory support to be delivered directly to the lungs. And this also allows patients, if they are able to take in things orally if need be. And then moving on, this patient also received a PEG, as I mentioned, and a PEG, it provides an alternative route to provide nutrition for those who cannot eat orally, whether that is due to mental status or difficulty swallowing, anything that precludes them from oral intake, as TPN or nutrition delivered via an IV can increase the risk of infection and other complications. And so this allows for nutrition to be delivered directly to the stomach through this tube, and it is placed through an endoscope. Moving along, I wanted to discuss the clinical correlates, which are for the indications for tracheostomy and PEG. So tracheostomy, emergently, indications include acute airway collapse and failure of less invasive airway stabilization methods, such as in cases of upper airway obstruction, infection, and severe facial fractures, including Lefort type 3 fractures. And then elective indications include individuals requiring prolonged mechanical ventilation, including cases of high cervical spinal cord injuries involving the levels at or above C345 as those supply the phrenic nerve to the diaphragm. And then also patients who have experienced neuromuscular disease have anticipated airway obstruction or prolonged recovery after trauma. And then indications for a PEG tube include individuals requiring prolonged nutritional support greater than 1 month with moderate to severe protein-calorie malnutrition, including in cases of stroke, trauma, neurologic diseases, and malignancy. For this patient, the indications for the tracheostomy included the prolonged mechanical ventilation and prolonged recovery after trauma. Because this patient was able to have a successfully less invasive airway stabilization at the time of initial presentation, then this Lefort type 3 fracture did not automatically require them to get a tracheostomy, but that could have been an indication in another scenario if failure of the less invasive airway stabilization had occurred. And finally, because of the trauma and requiring prolonged nutritional support, the patient also had an indication for the PEG tube. And then finally, the patient remains in critical condition in the ICU given the quite profound extent of injuries. And with continued clinical stabilization and improvements, the patient will likely require extensive rehabilitation. This includes an intensive multidisciplinary approach to recovery, both inpatient and outpatient, including physicians, such as intensivists in the ICU, physiatrists or physical medicine and rehabilitation physicians in the inpatient rehab setting, and any number of specialists such as GI specialists, neurologists, neurosurgeons, cardiologists, pulmonologists, anyone involved in their care. In addition to APPs, nurses, physical, occupational, and speech therapists, dietitians, social workers, psychotherapists, pharmacists, and family and social emotional support networks. As you can see, this is an incredibly complex and wide reaching team, but it's so important that patients that have experienced catastrophic illness and injury have all of the supports that they need in place to succeed. And despite extensive severe injuries, patients often can regain function, independence, and quality of life. I personally am very passionate about this final point as I am applying into physical medicine and rehabilitation, a specialty designed at helping patients restore function and recover after catastrophic illness to improve independence, function, and quality of life. And while patients can have an incredibly wide variety of illnesses or injuries that cause them to lose function, independence, and quality of life, it's really quite remarkable just how far science has come and just how far we are able to help patients bring back the quality of life that they deserve. And then here are my citations. Thank you very much.